will be having two lectures. Each lecture will be of 30 minutes and which will be followed by about 10 to 15 minutes of the question answers. Then the first speaker, we have a very renowned international speaker, Dr. Fadi Nibhan, who has very graciously agreed to come to this session. He is a consultant endocrinologist, associate professor of medicine, Division of Endocrinology and Diabetes and Metabolism in the Ohio State of University, Columbus, Ohio, United States of America. He has management of thyroid nodules and thyroid cancer as his areas of interest when research is concerned. Today, he will be discussing thyroid nodules, when to perform fine needle aspiration biopsy, and how to manage indeterminate results. Very important topic, we all agree to that. Our second lecture will be basically a debate between two of our very well-known consultant endocrinologists, Dr. Atif Munir, who is a name well-known for his work, especially for Meethi Zindagi, and he's a consultant endocrinologist in Fatma Memorial Hospital. He will be joined by Dr. Waqas Shafiq, who is also a consultant endocrinologist, a well-known name in Shaukat Khana Memorial Cancer Hospital. And they will be discussing Graves' disease, block and replace therapy versus titration. So we are definitely looking forward to a very productive session ahead. Taking this opportunity, I'd like to invite very respectfully Dr. Fadi Nibhan to kindly start the lecture and kindly take over now.
Thank you. Thank you, Dr. Uneeba. So I'm going to start with the dose titration part, and my colleague Atif is going to talk about block and replace. So this is going to be a debate for dose titration versus block and replace. So I will start this debate by this quote: "You don't win a debate by suppressing discussion, you win it with a better argument." So I will try my best to win this by a better argument. So in 1942, Astwood treated the first hyperthyroid patient with thiourea. And this was an era which is called as the golden era for hyperthyroid patient, because that's the time when propylthiouracil was introduced, methimazole was introduced, and carbimazole was introduced. And this was around the same time when the first patient was treated with radioactive iodine, first hyperthyroid patient with radioactive iodine. Prior to that, everyone with hyperthyroidism normally go under the knife of a surgeon. So this was the golden time for hyperthyroid patient. So we have more than 70-year experience of using antithyroid medications. And if I say that we have more than 70-year experience of using antithyroid medication in a titration regime way, then it will not be wrong. So let me briefly explain what exactly these regimes are. So the two recognized regime of antithyroid medication are dose titration. In dose titration, the dose of antithyroid medication is titrated based on thyroid function test. Block and replace, where a fixed dose of antithyroid medication is combined with thyroxine. So let me explain the benefits of dose titration. So first, we have wide-based experience, evidence-based experience. As I say, we have been using this regime for more than 70 years. In dose titration way, we will be using less tablets. Compliance is always an issue with our patient, and you definitely don't want to give more tablets to the patient. In dose titration, you will start, for example, on 30 or 40 milligram of carbimazole, and then after 2 months, you reduced it and then adjust your medication according to the patient response of thyroid function. Other benefit is possible less side effect with dose titration. Now, I have put the word possible here because there is no clear evidence that dose titration is better in terms of side effect profile. There is some studies which actually showed that with block and replace, people develop more neutropenia. Although in those studies, the dose of the carbimazole was pretty high as compared to the usual clinical dose which we use. Now, hyperthyroid is a disease which is most common in female of reproductive age. So with dose titration, you can continue the dose titration provided you are monitoring their thyroid function test with the aim to keep their thyroid in the normal range, you can use the dose titration in pregnancy, whereas with the block and replace, it's contraindicated in pregnancy. So the safety profile of dose titration is better as compared to the block and replace. So early advocates of the block and replace suggested a high remission with block and replace. It was also proposed that block and replace provide greater stability in the thyroid function. Hence, the patient required less thyroid function and clinical visit. So now I'm going to look at the evidence. Is this suggestions that there is high remission with block and replace and more stability of the thyroid function? Is there any evidence for this? So let's come to the evidence. So in 1991, Huzum et al. Reported that the rate of hyperthyroidism recurrence after stopping antithyroid could be reduced significantly by using block and replace. And this was the first time when the block and replace was introduced. This study was done in Japanese population. However, multiple subsequent studies failed to reproduce these results. A systemic review by Abraham et al., which was published in European Journal of Endocrinology, showed there is no evidence in terms of remission of hyperthyroidism with block and replace. And in systemic review, they reviewed at multiple studies. Now looking at the stable thyroid function. So this study, block and replace regime versus titration regime of antithyroid drug for the treatment of Graves' disease, a retrospective observational study. This study was done in Exeter, UK. So the objective of this study was to study whether in routine clinical practice, block and replace regime compared with the titration regime is associated with more stable thyroid function. It was a retrospective study. So if you look at the baseline characteristic, so this part is the block and replace group, and this part is the titration group. And this is a part where they were given both titration and block and replace. However, in the outcome, they only include these two, block and replace only and titration. And they are pretty similar in terms of characteristic, except that in block and replace, there were more people with thyroid eye disease was included. You can see here 15.5 as compared to 6.3 in titration. And also the relapsed thyrotoxicosis as referral, you can see there were more people in titration group. Now let's see the outcome. So first, number of TFT per year. Block and replace 3.2, titration 3.4. Yes, there is a difference of minus 0.4, which means 0.4 less thyroid function per year between the two. Number of abnormal thyroid function per year, 1.8, 1.8, no difference. Patient with at least one abnormal thyroid function in first 3 months, 77.1, 67.1, no difference. Patient with TSH more than 20 at any time during follow-up, 9.9, 6, no significant difference. Patient with free T4 more than 48, which means thyrotoxicosis at any time during follow-up, 46.3, 36.2, no difference. In fact, titration profile is a bit better. Number of follow-up per visit, 2.9, 3.2. Yes, the block and replace did reduce the clinical visit. So let's see this outcome. So there is no evidence that patient on block and replace have more stable thyroid function. Patient on block and replace was seen slightly less often in the hospital, on average by just under a clinic appointment per year. Patient on block and replace need less thyroid function. Similarly, on average by just under a test per year. Now, my colleague Atif, who is going to talk in favor of block and replace, might argue that the study which I mentioned was a randomized controlled trial, a single center study. So there can be multiple bias. And also, I noted that there are a few societies which suggest to use the block and replace in patients with thyroid eye disease or in young patients. I try to look that either there is any prospective study in terms of thyroid eye disease. There was no study I found, but I found a very interesting study which was published in 2020 this year in European Journal of Endocrinology. This was a pediatric study where it's a multi-center, open-label, randomized trial comparing block and replace with dose titration in patients aged 2 to 17 years with newly diagnosed hyperthyroid at 15 UK centers. Patients were randomized shortly after diagnosis and treated for 3 years. So the primary outcome of this study was percentage of serum thyroid function level in the reference range between 6 months and 3 years. Secondary outcome included the proportion of free thyroxine level in the reference range, adverse event frequency, and 4-year outcome, either remission or relapse. So the results: 81 patients were randomized, 40 were allocated to block and replace, and 41 to dose titration. So the primary outcome, the mean percentage of serum TSH with reference range was 60.2 in block and replace and 63.8 in dose titration. So no difference. Let's come to the secondary outcome. So the proportion of free T4 was 79.2% in block and replace and 85.7 in dose titration. No difference. 3 patients developed neutropenia, all on block and replace. 6 block and replace and 10 dose titration patients were in remission at 4 years. So in conclusion, dose titration is safe, effective, and evidence-based treatment for hyperthyroidism. There is no evidence to support that block and replace improve the outcome of patients with hyperthyroidism. I will finish my part by this quote from Margaret Thatcher: "I love argument, I love debate. I don't expect anyone just to sit there and agree with me. That's not their job." So I expect Dr. Atif to proceed from here. Thank you.
Thank you, Dr. Waqas. We'll take the questions afterwards, but now I'll invite Dr. Atif Munir for the second part of the debate.
Okay, thank you. So am I audible?
Yes, Dr. Atif, you're audible.
Excellent. And you can see my slides.
Not yet.
Okay, just a second. I need to share my screen. Sorry for this. Yep.
Yes.
Excellent. Let's make a start. So thank you very much, Waqas. And there we go. Okay, so no disclosures, no conflict of interest to declare. My colleague has put up a very strong case for dose titration. And this is election season. I'm not going to concede, but Waqas, neither I'm going to file a lawsuit. So let's move on. Let's fight evidence with evidence. Yes, you have used 2 quotes, so that puts me under pressure to use 2 quotes as well. Here comes the first one. It's a one-liner. Picture abhi baki hai mere dost. Let's make a start. So this is the evidence I'm going to scrutinize to convince you guys to use block and replace for your Graves patients. This is a meta-analysis by Abraham and colleagues, and this is to date, as per my limited understanding and knowledge, is still the largest meta-analysis to date, comparing the both regimes for anti-thyroid drug regime for treating Graves' disease and hyperthyroidism. So we know that doses from the block and replace arm and the side effect profile historically has put people off, or endocrinologists off, in using this regime. But the evidence needs to be scrutinized very carefully, and we need to read between the lines. And this is what we could do together over the next 10 minutes. So let's have a look. So these are the studies that have been used in this meta-analysis for comparison of both arms of treatment. As you can see, the drug dose used in block and replace arm for the for the carbimazole and the methimazole is ranging from 60 milligrams to 100 milligrams per day. So these are the sort of doses that have been used in most of the studies that have been comparing both the arms. Now, in actual clinical practice, we don't usually use 60 to 100 milligrams for block and replace therapy. The usual standard dose that we use in everyday clinical practice is around 40 milligrams. The 7 studies that I've quoted out of the meta-analysis have used higher than the conventional clinical practice doses. If you study these studies in detail, the aim was primarily to see if remission rates could be obtained with higher doses. So this was the primary outcome, that if we can have improved remission rates by using higher doses. And as Waqas has pointed out, the meta-analysis concludes that the remission rates were equal for both block and replace and titration, irrespective of the doses used. The remission rates stand at about 40% after 2 years. So, the relapse rate stand at about 40% after each regime. So there was no statistical difference between remission. Hence, not much point of using doses higher than what we usually do in our clinical practice every day. On this note, titration cannot be recommended as first-line treatment for Graves' disease. The other thing that people, after these 2 papers, although they're fairly old papers, this is where the real fear for block and replace stemmed from. These papers kind of concluded that the prevalence of agranulocytosis risk was dose dependent. And we've been using around 40 milligram of carbimazole in block and replace, and we continue this dose throughout the treatment. Whereas in dose titration, you tend to start higher and then cut back as per serial thyroid function test results. So these 2 papers kind of put people off quite a lot in using block and replace, just in view of the fear of agranulocytosis. But this fear was blown away by Simon Pearce's paper. Professor Simon Pearce, I've had the privilege of working under supervision of being trained by him and then being his junior colleague at the Newcastle Hospital. And Newcastle is for my colleagues who have been trained in UK. Newcastle is the center which is the biggest advocate of block and replace therapy in Graves' disease around UK, and a lot of evidence for promoting block and replace has stemmed from Newcastle. So I'm proud to be a Newcastle ambassador in this context. So Professor Pearce showed the peak time of agranulocytosis incidence was around 4 to 6 weeks of starting the therapy. This was based on 117 case reports of agranulocytosis from 1963 to 2003. So over a span of 40 years, 117 case reports of agranulocytosis. And if you look at the graph, the major chunk, rather the whole chunk of agranulocytosis is occurring between 4 to 6 weeks of starting therapy, be it propylthiouracil, be it carbimazole. We know whether we use block and replace or titration that for the first 4 to 6 weeks, either arm, patient in either arm is on a higher dose of carbimazole, usually 30 to 40 milligrams. So just based on that, you can safely conclude that the dose is same in both arms. Hence, theoretically, the risk or practically the risk of agranulocytosis should be similar. So first 4 to 6 weeks, the risk is similar. Hence, you can't advocate one arm over the other. If you scroll down this evidence, the studies quoted in Abraham and colleagues meta-analysis, if you tease out the agranulocytosis thing from these studies, the whole meta-analysis, there were 12 episodes from 5 studies. About 1/3 were of the people who developed agranulocytosis were in the highest dose studies using 100 milligram or 60 milligram, which we don't use in everyday clinical practice, as I've said. And there was no statistically significant difference between the risk of agranulocytosis between either arm, block and replace, and titration. So as far as the agranulocytosis risk is concerned, it's the same for both arms. The other thing that is that kind of shies people away from using higher doses throughout the course of treatment, and as we do in block and replace, is the incidence of rash. So again, going back to this meta-analysis, if you screen out the incidence of rash for both regimes, there's about 9.8% in block and replace, 5.8% titration. Yes, much higher in block and replace. But you look into the details, there was no significant difference in the incidence of rash by the study which contributed more than 50% of patients to this meta-analysis, which was by Banker and colleagues. So if one study which is contributing more than 50% of the patients to a meta-analysis has no significant difference between the incidence of rash, then it is safe to conclude that the incidence of rash is equal for both arms in majority of patients. If the two studies using the highest doses of thienamides, which include 60 to 100 milligram doses, are excluded, then there is no significant difference in incidence of rash between the two arms. So that boils down to being a kind of an idiosyncratic reaction rather than a dose-related phenomenon. Other advantages, and this is where I will spend some time. Block and replace versus dose titration. We know a significant proportion of people with Graves may have thyroid eye disease to begin with, or may develop thyroid eye disease during the course of treatment. And one of the potentially precipitating factor for thyroid eye disease, once they are diagnosed and don't have thyroid eye disease to begin with, is hypothyroidism. With dose titration, there is more risk of inducing hypothyroidism and hence precipitating eye disease. And we do see such patients in our everyday clinical practice who had no eye disease to begin with. We had iatrogenic hypothyroidism for treating Graves with dose titration due to multiple reasons. The test being delayed, patient not turning up, follow-up, etc., whatever. And they end up having eye disease. So you don't want to cause eye disease, or don't want to precipitate eye disease. This is one thing you don't want in Graves' disease. So dose titration regime, patients are prone to periods of hypo and hyperthyroidism, which has some evidence being linked to progression of eye disease and affecting quality of life. Block and replace, you'll need less clinic visits and monitoring. Now, in the part of the world where we all practice, we know that follow-up is a bit of a tricky thing when it comes to a condition which is not life-threatening. Even for life-threatening conditions, our patients are pretty casual about their follow-up. So for a condition which is not life-threatening, but potentially can be site-threatening, it is very important to have regular follow-up and clinic visits. With block and replace, you need less clinic visits. Remember, the part of the world where we practice, there's a cost element attached to it as well. It's about blood tests. We live in a country where T3, T4, TSH are charged separately from the patient's pocket, not as a whole. So less clinic visits, less blood tests, hence it is more cost effective, especially for our part of the world. Whereas in dose titration, it's kind of 6 to 8 weeks you have to call the person back for tests and monitoring. Now imagine in a country where the situation is pretty dire with respect to all other economic parameters. Would you want to see this patient every 6 to 8 weeks with a repeat thyroid blood test in your clinic? If yes, how many would actually turn up and how many would be lost to follow? Just think. Now the key point. That's a clinching point for block and replace as well, on top of other factors. The optimal remission rates, which is about 60%, equal for both arms. But if you look at this meta-analysis, the optimal remission rates with block and replace are after a duration of therapy of 6 to 12 months. Whereas for titration, the optimal remission rates are after a follow-up of 12 to 18 months. Again, less clinic visits, lesser duration of therapy, and will definitely ensure compliance, concordance, and follow-up. So we've got a regime in the form of block and replace where you need less visits, less tests, and a shorter duration of therapy by about 6 months. So that's pretty attractive for the patient if you put the patient's perspective in as well. So combining experience, because I've been using block and replace since I was being trained, so it's been quite a few years. So now combining experience with evidence that I've shown you, let's draw my conclusions. So modest doses of thiamides as block and replace, which is carbimazole 40 milligram, is a good choice to treat Graves. Side effect profile at doses used in current clinical practice are statistically similar to dose titration. There is significant advantage of using block and replace over titration in thyroid eye disease patient because you want to ensure an absolutely stable euthyroid state. You need less frequent monitoring and clinic visits. You get optimal remission rates comparable to titration. Yes, I know it's not better in terms of remission, but it's comparable. So your patient and you as a clinician would love to have a comparable remission rate with half the duration of therapy. But until we have equi-power trials of both regimes with commonly used doses as we use in clinical practice, I think, yes, theoretically, you may not be able to choose, but definitely from a practical point of view, block and replace does have an edge until we have better evidence available in the form of equi-power trials of both regimes. With this, I conclude with Michael Jordan's quote. Because you gave two, there's my second one. Some people want it to happen. Some people wish it would happen, and others make it happen. So go for block and replace and make it happen. Thank you very much.
Thank you so much, Dr. Atif. We just had two very convincing debates, and I'll request Dr. Umal to kindly comment.
Thank you, Dr. Uneeba. Thank you, Dr. Waqas. Thank you, Dr. Atif. I must say that I personally have never used block and replace, but Dr. Atif's presentation was more convincing than I thought it would be. But I think I'm going to reserve my comments to the end. And meanwhile, I'm going to ask our panelists to see what they think and what their experience is. So starting with Dr. Sara, please go ahead.
Thank you, Umal. So Dr. Waqas and Dr. Atif, I think both of you gave compelling arguments for your cases and tried to put up the best data that is available. But like Umal said, I mean, I've been US trained and I've never done block and replace, and so I have an inherent bias against it. But I listened to your argument with an open mind, or I tried to. So I wanted to make a point about the cost thing. I know you mentioned, which is a valid point, that in our part of the world, a lot of people to come back and have TSH54 tested separately, the money adds up, right? But I guess taking both numercazole and levothyroxine together, I don't think there has been any research study to see what those costs would be to add up. And then the potential cost of having that rash evaluated, if that is done, because they may not recall that you had warned them that it could be the result of this. So for me, Waqas wins.
Okay, before we move on to our next panelist, I would also request all the audience, if they can, just by sending in through the portal, can tell us which method they prefer, especially after listening to both sides of the debates. Please go ahead, Dr. Ahmed Imran.
Yeah, so a couple of excellent presentations. I think, I suppose you're in the right job. I think you could be very good lawyers if you were to convince people for your case. I think I'll say a couple of comments, and I think one for each, and I hope that will bring a smile to the face of each of my colleagues. So for Dr. Atif, I completely agree that for challenging patients with rapidly fluctuating thyroid functions, I think block and replace has an edge because it will put the thyroid to sleep. And that does work because I have used it for some of my patients. Having said that, we got to be aware of the fact that the way the thyroid hyperthyroidism treatment is evolving at the moment is that we are not only looking at biochemical conversion, we are also looking at the seroconversion, which is the thyroid receptor antibodies to turn negative. So the whole talk about these two treatment regimes, they are focused on biochemical conversion, where the thyroid function normalizes, and then you expect that there will be no relapse. However, in order to prevent the relapse, there is more work being carried out on the titration regimes. So there are studies using carbimazole for 95 months, which is showing that there's a 5-time reduction in the rate of relapse by Azizi and et al. Similarly, there are studies that are showing that if you use low-dose carbimazole, 2.5 to 5 milligrams a day, over a period of another 4 years after the 2 years, provided the TSH receptor antibodies were positive, then the rate of relapse is much lower. So I hear what Dr. Atif said, and I completely support for rapidly fluctuating thyroid functions. But I did not find any evidence in the literature supporting that treatment that is it evolving, because for the titration regime, that seems to be evolving over the time. We now have TSH receptor antibodies. We are increasing the duration of the treatment in order to prevent the relapse, which means subsequent potential use of radioiodine, potential use of thyroid surgery. So along these lines, I think the titration regime is giving us the next steps in the treatment of hypothyroidism. That's why some clinicians may feel attracted or may feel inclined towards using that form of treatment.
Thank you, Dr. Ahmed Imran. And whilst the poll is going on, I'm going to request Dr. Amena Moazzam to please give her comments on this.
It was an exciting and excellent discussion between two consultants. And to start with, I would like to comment on Atif's block and replace regime. Since I was trained by a British trained supervisor and myself am a graduate from abroad, I have used block and replace in my patients a lot. And it has worked out for few patients. The number has been small, but nevertheless, I have used it and I do not rule out it completely. Basically, we use it in patients who are young, who have mild eye disease, and who have fluctuating thyroid levels, as explained by Dr. Ahmed. However, because of the large chunk of patients and physicians preferring titration dose and patients not opting for a regime with a high pill count, I think titration dose takes the marks. And if titrated appropriately, we can avoid side effects. It's used in ladies who are pregnant, who have moderate to severe eye disease, and especially patients with multiple comorbid diseases. So yes, my vote goes for titration regime, but nevertheless, I would not like to rule out the block and replace regime. It is and it can be used in certain patients, though the number is small, but it can be used effectively. Back to you, Umal. Thank you.
Thank you, Dr. Amena. Thank you very much. We've got a couple of questions polling in, so I'm going to start by asking these questions, and either one of you, Dr. Waqas or Dr. Atif, can take them up. Some of these are actually just comments. So the first one, in block and replace regimen, in which the patient is already hyperthyroid, after how much time would you suggest introducing thyroxine after carbimazole? And would thyroxine be the same starting dose, or is it different for each patient?
Okay,
I guess
so
this is you, Dr. Atif.
Yeah, thank you. So yeah, that's a really practical question. That's what we do day to day with block and replace. So yeah, we would usually start with full 40 milligram of carbimazole, irrespective of how toxic they are. The only decision that you will make when to call them back with a repeat thyroid function test would depend on the toxicity. If they are very toxic, and the term very toxic comes with experience, really. So I would call them after 4 to 6 weeks. If the T3, T4 has near normalized or normalized, I would add levothyroxine full dose, the usual dose we use for replacement in hypothyroid patients. If the person is not that toxic, I will call them back early, like 3 weeks. And as I said, if the T3, T4 are near normalized or normalized, I would add thyroxine full dose. And this is what you do for the course of the treatment. This is a starting dose. You might have to tweak either thyroxine dose or the neomercazole dose or carbimazole dose as you go along. But this is how we usually go about block and replace. As far as the cost of levothyroxine is concerned, it's probably the cheapest medicine available in our country.
Can I ask a question from Atif?
Sure, go ahead.
So, Dr. Atif, you mentioned that this block and replace can result in more stable thyroid function. But looking at the literature, looking at the evidence, there is no study which actually compare the stability. So the studies which I looked at, there was no study which showed that the thyroid function is more stable in block and replace as compared to titration. So is there any study which actually prove your point?
I agree with your point, but the study that you have shown is not also showing, the study that you have quoted also not showing any advantage of titration, any statistical advantage of titration. And just the very fact, so there is no study related or evidence based advantage, but potentially theoretically, and because I've been using it for such a while, it does ensure a lot of stability, because it just makes sense. As long as the patient is taking both the tablets and not playing with the tablets, then you've kind of blocked the factory, the production, and you're just replacing it. So as long as the person is taking those two things that you have prescribed as per your prescription, there is usually no or hardly any or very minor alteration in the thyroid status.
Thank you.
Okay, so there's a comment, good arguments from both sides. There is no good quality evidence to unequivocally prefer one over the other. Having used both types of regimens in the UK, I personally prefer dose titration over block and replace, simply because keeping patients on higher dose of carbamazole for longer periods is associated with higher risk of adverse events. This is one of the comments. Then from patient safety perspective, titration is clearly a better option. Then another one, block and replacement regimen needs education and disciplined people. What is the percentage of that? What is the percentage of that sort of population that you see? I think that's a very valid question, actually.
Waqas, you want to go first?
I think I don't have the exact figure, but the one point which I want to add here is, because in a country like Pakistan, where you don't have like multiple endocrinologists here, there is a handful of endocrinologists, and they are mostly in the cities and in the big cities. So with titration method, which has been used for more than 70 years, you start on tablets, then their thyroid function are checked. So even a general physician can understand it and can manage it. Not ideally, but with block and replace, is not possible. It can only be done in an organized, like in a well-developed setting where endocrinologist is there. You explain everything to the patient. But my argument still will be that, do we really need to? Yes, you have one point that the duration might be less. But even that is not proven in studies. I accept that in the meta-analysis, they included the studies where the duration was less in the original studies. But if you look at the later studies, the duration is not significantly different. I might be wrong, but that's what when I go through all this data.
I would like to make a comment on the comment that's been posted. So as far as the side effect profile is concerned, I think we have pretty good evidence, as we've seen, that the side effect profile is really not an issue in continuing high doses long term, as I've shown. And as far as the education bit is concerned, yes, right. But that's like with every chronic health condition, it is you who will be educating that person, or if I not call them patient. The very heavy onus of education lies with the person treating the condition, and I think it's a two-way traffic. I would quite like to know how many endocrine centers in this country have a carbimazole agranulocytosis risk information leaflet, because there is a big onus on our side as well, because that's one side effect you are really concerned about. I know it's pretty rare, but that's one thing, and that's the same for titration and block and replace. So there's a big onus on us as endocrinologists for this. It's a two-way traffic.
Okay, Dr. Atif, just a couple of more questions in the interest of time, then I'll make some concluding remarks. So why is block and replace contraindicated in pregnancy?
Okay, so you don't want to give someone thyroxine because it's going to cross, and you're just going to end up suppressing the fetal thyroid gland. Plus, you don't want to use higher doses as we use for block and replace carbimazole and either propyl thyroxine, because you want to keep them at a bare minimum. Both are fetotoxic to some extent. PTU being slightly less fetotoxic than carbimazole, and you want to use the lowest dose. Although there's not a wealth of evidence in dose-related stuff, but there is some evidence that higher the dose, the greater the risk. So these are the two primary reasons.
And then the last question I'm going to take is block and replace. Is block and replace safe for old age and with patients with other comorbidities?
Well, that's a very good question. You have to individualize treatment as with any other health conditions. So obviously, if you have an old, frail patient with cardiovascular disease, et cetera, heart failure, then yes, you will really prefer not to add thyroxine because you might end up just precipitating the heart failure, or maybe worsening the atrial fibrillation, et cetera. It does need to be individualized. But if the comorbidities are stable, well controlled, well, it's a judgment call really. Otherwise, you are right. Multiple comorbidities, old age, frailty, especially cardiovascular, you would tend to favor titration.
Thank you very much. So the polls have actually showed people are mostly doing titration method in Pakistan, and that's what they prefer. That's what the polls have shown. And as Dr. Sara said, I'm also US trained, so I've never really done block and replace. So at the end of the day, I think it really matters what sort of patient you have, because I think you would need to select your patient very carefully for block and replace versus titration, because commonly there are patients, if I have them on 2 diabetic medications even, they'll stop taking one and they'll continue taking the other. And that is still okay. But if a patient stops taking, for example, levothyroxine and continues to take carbimazole or does it the other way, we could end up in a lot more trouble than we would in the titration method. So I think if the patient population is properly selected and patients who have very rapidly fluctuating TFTs, in that sort of selected patient population, this might be a better idea. But I think overall, I would still use titration as my main method of treatment for these Graves' disease patients. But points very well taken. Thank you very much. Over to you, Dr. Uneeba.
Thank you, Dr. Umal. We are towards the end of our very productive session. I'd like to thank both of our speakers and the expert panel, obviously, and especially Dr. Umal for the very smooth running of the session. Thank you, everyone.
Thank you, Dr. Uneeba. It was a pleasure.
Thank you.
Thank you, everyone.
Thank you.
Thank you. Bye-bye.
Allah.
Bye. Allah Hafiz.